Okay, I'm starting the recording, and this is the Juneau Gastineau Rotary Club on November 12th, 2020. We are pleased to welcome today Robert Barr from the City and Borough of Juneau. And we last heard from Robert in his capacity as our librarian. And now with the pandemic, he has been forced into the role of coordinating a lot of our testing in response to the COVID. So thank you for being here again, Robert, and we're looking forward to hearing what you have to say. You can screen share if you like, or just take it away from here.
Thank you so much, Amy. Amy, could I do a quick time check? I want to make sure I leave time at the end for questions. About how long should I go?
Well, we have till 8 o'clock pretty much, right, Doug? Is there anything else we need to cover at the end? I think we're good till 8 then. Yeah.
Okay, great. Thank you so much. It is so great to be with you all today. I've been really looking forward to this. I recognize many of you, and I know many of you well. As Amy mentioned, in my pre-COVID life, I was the library director. I still do a little bit of that, but mostly I work in the Emergency Operations Center as the planning section chief. We operate under a unified command structure, which probably many of you are familiar with. It's the same structure that most organizations use to respond to emergency types of situations. And of course, unlike most emergencies that last a weekend or a week or maybe 2 weeks, this one has been going on for quite some time now. It's the longest we've stood up an EOC by far, I'm sure. I'm here to talk mostly about the testing aspect of our COVID response, although I can certainly talk about other ways in which the CBJ and our unified command, which is made up of the CBJ, Bartlett Regional Hospital, and the Division of Public Health, have acted in ways that we've operated. So I'm really looking forward to questions at the end too. So I do have some slides. Oh, and before I get started with the slides, I did want to give a quick shout out to Rosemary and Dave Wetzel. They both have been meeting with me weekly and with me and a larger group of people to provide some sort of high-level oversight and guidance to our broader testing operations too. So thank you both for your participation in that and your good work there. It is much appreciated. So I want to start by talking a little bit about what we're doing operationally. So we've had an operation at the airport right now for a number of months where all arriving passengers are screened up here in the second floor. And then let's see if I can advance slides here. Just a couple more pictures of our screening operations. So most of you have probably experienced this already, but you come through the airport, you talk to one of our staff, it's primarily staffed by CCFR, and get asked a bunch of questions and make sure you filled out your travel mandate associated with Health Mandate 10. And then if it's appropriate, depending on where you traveled from and if you traveled from out of state or not, you'll get tested downstairs. And we've actually recently moved our testing inside, so it doesn't look like this anymore. And that's been going really well. The bulk of the testing that we do in Juneau right now happens at our airport, and that is all asymptomatic testing by and large anyway. So those are people who aren't experiencing any symptoms. And we do somewhere around 100 to 150, I would say, tests every day at the airport. Recently, it has ebbed and flowed as travel has ebbed and flowed. In addition to our airport testing, we test out at the Hagevik Fire Training Center. So this is a picture of that. And we do two types of testing out here. In the mornings, we do testing for people who are getting ready for a medical procedure, generally at the hospital. And so anyone who's going to get a medical procedure gets tested 72 hours or less before their procedure and then told to quarantine. And that's to keep our healthcare workers safe and make sure that that medical procedure goes well, because often those need to be in very close contact when that's happening. And then in the afternoons at the fire training center, we do testing for people who are experiencing symptoms. And we do quite a bit of that. That varies from day to day too, anywhere from 10 tests all the way up to 100 or 120. depending on what's going on in the broader community. And we have been asking now for quite some time everyone to get tested if they are experiencing even the slightest COVID symptom. One of the things that we've learned about COVID over the past period of time is that in many people, it can be just the slightest symptom that ends up being COVID, just a tickle in your throat in the morning that's unusual for you, or you know, a bit of congestion that seems odd or off, but no big deal. So we staff a hotline with a number of staff, 7 days a week from 8 to 5, and anyone who has symptoms, we ask to call that hotline. It's 586-6000 and schedule time to go out to the testing center and get tested, and it is free. So there's, when thinking about COVID testing broadly, there's 3 sort of big categories: diagnostic, antibody, and environmental tests. And those seek to answer different questions, right? So the environmental tests are the ones that I'll talk about here first. And that's trying to answer the question, is there general sickness, or in this case, COVID, in the broader population? The antibody tests try to answer the question of, have you been sick with COVID in the past, but presumably are no longer? And then the diagnostic tests are the ones that we do the majority of. That's what we focus on, and that tries to answer the question of, are you right now sick, or are you coming down with COVID? So environmental tests, as far as COVID goes, focus on trying to detect COVID in wastewater. So in our sewage system, in our gray water and black water systems, we have been testing those for some time now. And I put this slide in here because Homer was one of the first municipalities, probably the first municipality in Alaska that started testing wastewater and started finding COVID in their wastewater. If I had had time to update this, I would have put in a graph of our current data. Suffice it to say, we're still pretty early in analyzing our local wastewater. We are detecting COVID at all 3 of our treatment plants, JD, Mendenhall, and Dock Bay, but at low levels right now. And we don't yet have enough data to draw any correlations or to make any good, accurate predictions about where we're going strictly from an environmental testing point of view. But we are going to continue doing that at least through the end of the year to see if it generates any good data to help us make any predictions or help us inform the community about how that's looking. It's thought, but the science is still really in its infancy here, but it's thought that that wastewater detection precedes detection via diagnostic testing, right? So it's thought that you shed COVID through your feces, through wastewater earlier than symptom onset. But it's like I said, the science is really in its infancy there. So we're doing it in the hopes that it'll prove useful, but it hasn't yet. It's kind of the summary there. And then antibody testing is kind of the next one that I won't spend a whole lot of time on. If you hear of a serology test, or if you get a blood test for COVID, those are all antibody tests. And I put this in here because I like this graph up here in the, let's see which screen is sharing, this one over here. I like this graph over here because it really, I think, simply explains what an antibody test is trying to do. It's trying to detect the presence of these antibodies, which generally have a long tail and hang out for quite some time after your illness. And it can it's not recommended for this use. It can, detect antibodies early while you're potentially still sick, but its primary use is to confirm a case of COVID after the fact. And so what I want to spend the bulk of the time that I have with you all today is talking about diagnostic testing. So there's a variety of different types of diagnostic testing, and I'm going to spend time talking about 2 of them. One is PCR. PCR stands for polymerase chain reaction, and that is the type of testing that we do in Juneau today, primarily. And you can think if you've had if you've been to either of our testing sites, or probably if you've been to your primary care physician or a private medical facility and had a COVID test, it was almost certainly a PCR-based test. And that's thought of as the gold standard of test right now. So what those PCR tests do is they take a sample, a specimen of your nasal mucus, and that gets shipped off to a lab. And the lab attempts to detect the genetic material of COVID, the RNA of COVID, via this polymerase chain reaction. And basically what it's doing is it's finding that viral sample of RNA, that count of RNA, and there might only be a couple of strands of RNA of the virus in that sample, and then it's amplifying it, and it amplifies it, 20, 30 times up to a point to where the lab equipment can actually visually or optically see the presence of COVID and throw a positive result if it's actually positive. So that's how PCR works. It's looking for that genetic material. And there's two kinds of PCR that we spend our time thinking about. One is the type that requires a complicated laboratory environment to do that detection work. And we don't yet have that type of complex lab in Juneau, although we will soon, and I'll talk about that later. But to date, we've primarily been using the state public health laboratories in Anchorage and Fairbanks, and we are also currently using a laboratory in Southern California that's a private commercial laboratory. And of course, when you're using a lab out of town, that increases your turnaround time, right? Because your samples are spending about 2 days in transit, and then of course you have to add on the time of the processing time in the laboratory. So that's the bulk of how this works. There's also a couple of devices that can do PCR-based tests at the point of care. And so when you hear about rapid tests, that's what this is. There's two types, there's two vendors that we've been working with to do rapid testing in Juneau, Cepheid and Abbott. And the way that those work, they're entirely proprietary systems. There's two parts to them. There's the test kit, and then there's the machine that the test kit goes into. And it's still a swab of the nose, still the same collection method, and that sample of mucus, that specimen goes into the test kit, and that test kit goes into the machine, and the machine takes somewhere between 20 and 60 minutes to perform that same type of polymerase chain reaction experiment, if you will, in that system, and return a result. The challenge with rapid testing is that both the machines and the test kits are in incredibly short supply, and it is the demand far outstrips the supply. So we are only able to get a very limited amount of rapid tests shipped to us in Juneau, and I'll talk more about that later too. And then the other type of testing is antigen-based testing. The other type of diagnostic testing, I should say, is antigen-based testing. And antigen, the way that antigen testing works is instead of trying to detect the genetic material of COVID, instead it's trying to detect a protein that the virus produces. So we've all seen the picture of the cell of COVID, that spike, it's not a cell, but that spiky sort of spherical depiction of COVID. And those spikes produce a protein, and the antigen tests attempt to detect that protein. It can be done in a point of care / analyzer. So there's machines and test kits very similar to the rapid tests with Cepheid and Abbott's. And then there are now some antigen test kits that you can think of as pregnancy tests. They're very similar to pregnancy tests in that it's just a single device. In the kind that we have right now are kind of shaped like a credit card, but they can also come in like sort of shaped like strips or in more sort of linear devices, and those have their uses too. So, and there's lots of other types of both antigen and PCR tests, but these are kind of the four big ones that we're focusing on here locally. And so I will talk about sort of where those are locally in a second. Before that, I want to talk a little bit about false positives and false negatives, because it's an important concept to understand when you're thinking about what tests we are using here locally. So when we think about false positives, the scientific term that is used to think about false positives is specificity. And so that's trying to answer the question of, if COVID is not present, does the test return a negative result? And so if a test returns a positive result for people who are healthy, so you don't have COVID, and the test says you do have COVID, we would say that's not very specific. It's finding something that isn't the disease, right? It's throwing a positive, but it's throwing a positive for something else. And that's what we mean by a false positive. And those PCR-based tests that I was talking about on the previous slide, those are very, very specific. They are really good at only finding that genetic material that PCR-based tests are looking for. Antigen tests, on the other hand, are a little bit less specific. One of the concerns that is sort of percolating through the scientific community right now, and again, the science is still a little bit out on this. One of the interesting things about COVID is it's a novel coronavirus, and we're learning new things about it all the time. But one of the concerns that is out there right now around antigen tests is, because it's detecting a protein that COVID produces, there's a concern that it can also be detecting a similar sort of protein that other coronaviruses produce that aren't SARS-CoV-2, right? Because there are lots of human coronaviruses, the kinds that give us the common cold and similar sorts of respiratory diseases, and they all produce similar sorts of proteins. So that concern is out there, and the specificity on antigen tests is generally thought to be not as good as the specificity for PCR-based tests. And then the other piece of this equation that we look at is sensitivity. And so that's trying to answer the question of, if COVID is present, if you've got it, does the test do a good job of actually detecting it? And so we would think of a false negative of occurring if a test returns that negative result for people who are sick, for people who have COVID, and it just isn't doing a good job at finding it. And one of the things that might sort of play a connection here in our minds is, we often talk about viral load, and there needing to be enough viral load in the sample, in the specimen, in order for the test to detect COVID. And really what we're talking about there is the sensitivity of the test. So if I'm exposed to COVID today, and I get a test tomorrow, there's no test in the world that is going to be sensitive enough to detect COVID in me just yet. It takes a few days for incubation to happen and for enough viral load to build up in my system for that test to throw a positive result. And so it's a similar story here between PCR and antigen tests. The PCR-based tests are generally much more sensitive than the antigen tests. And the PCR tests that occur in the laboratory environment, in the complex laboratory environment, are generally much more sensitive than the rapid tests. And that makes sense, because those labs generally, I mentioned that in a polymerase chain reaction, one of the ways that, or the way that test eventually detects COVID is it amplifies the amount of genetic material that it found. Well, in a lab, that amplification step generally happens over a 4-hour period, give or take. It can be less than that, it can be a little bit more than that, but it happens over a longer period of time on a much more complex piece of equipment than can occur in those rapid tests out in the field that take 20 to 60 minutes. And so that there's more time for that amplification process to happen over and over again. And that amplification process is an exponential process. So if you only do it a couple of times, you're not going to get as nearly as much of that RNA genetic material replicated as you do in a lab. So you need more. The summary to that story is you need more viral load to detect a positive COVID result in either the rapid tests or antigen tests than you do for those laboratory-based tests. So I talked a little bit about this, but this is kind of the process for how it works for us right now in Juneau when we're using that laboratory process. So you get swabbed, you get your sample collected, either via the sort of what we refer to as the brain tickler option, which we don't use very much at all anymore, or the one that just goes partway through your nose. It gets put in a specimen collection bag. It gets shipped down to our laboratory right now in Southern California. They process it in their lab, and then we result the test and communicated about that. We're actually, when I made this slide, we were at a 3 to 5 day turnaround. We're doing slightly better than that right now. We're down to 2 to 3 days for this lab that we're using in Southern California. We do still send some tests up to the state lab, and those continue to be a 3 to 5 day turnaround. And all of that turnaround time is dependent upon a variety of things. It's dependent on how much testing is going on. It's dependent upon supplies and et cetera. I think, we spend a lot of time thinking and talking about turnaround time because it matters a lot, right? The lower that time, the higher the value of the test. The sooner that you can tell someone, so a test is a point in time, right? It just tells you if it detected COVID or not when that sample was taken out of your nose. And the sooner you can tell someone that, yep, it was positive, or nope, it was negative, that informs behavior, and that informs containment of the overall disease. So I'm going to speed through the next couple of slides here because I really do want to take some questions. I talked a little bit about this already. These are the rapid tests that happen on a PCR machine. This is what the machines look like. We have a couple of these right now out in the field. The hospital has a couple of these. These are the Cephius, these are the Abbotts. The test kits are extremely limited. We don't get a consistent supply of those right now. We, back in June, the Assembly appropriated $700,000 for a piece of equipment that would allow us to process those complex laboratory tests at Bartlett. I included, this is the total amount of money in a pie chart graphic that the city received as the CARES allocation. And you can see I circled the testing equipment and operations little slice of the pie. It's that one right there. And that project is underway. So we expect to receive that analyzer in December. It'll take a month or so to get it installed and validated, and then hopefully we will be processing our PCR-based tests that we collect. First, the symptomatic ones, the fire training center, then the pre-medical procedure ones, and eventually the airport ones right here locally, so that we'll be reducing that turnaround time. And we've been working on this since May. And then there's this slide is just showing the Food and Drug Administration puts out a list of emergency use authorizations for all of the different types of COVID tests that are out there. When I captured the slide, there were 191 different vendors that had different tests out there that you could do COVID tests on. I checked yesterday, it's up to 290. We look at this every day to see if there are other good COVID testing options out there in the world that we can start procuring to use locally. These were all the different laboratory options that were under consideration when we were considering them. We're going with this one up here in the top left that probably doesn't really mean much to you, but that was the vendor that got back to us first. Basically, we put in purchase orders with a bunch of different vendors, and with the idea, with the caveat to each vendor that we were going to buy whoever could get it to us first. In general, you can do 350 tests per shift, per 8-hour shift on these devices. They generally cost $100 a test. You can generally get turnaround time same day or next day. So that's kind of what that looks like. And then I'll briefly talk about this from I like this graph because it gives you a sense of how much more sensitive the PCR tests can be than the antigen tests. So the x-axis here is days since exposure to COVID. Day 0 would have been the infection date, and the y-axis is the amount of viral load. And these are all averages. It's important to say that this can vary from person to person, from infection to infection. But generally, a PCR test is going to detect COVID somewhere around day 2, maybe day 3. or into day 2, whereas an antigen test is going to take a little bit longer, might be around day 3 or slightly thereafter. The COVID is thought to be transmissible in this box, right? It's thought to be transmissible, again, on average, slightly after day 3 since exposure. And so both tests can detect COVID before you become transmissible, again, on average. That's super important. But the PCR tests are generally better at it. So I think that's helpful. And so I've already talked a little bit about this antigen test, so I'm not going to go into detail on this slide because I'm sensitive to the fact that there's only 4 minutes until 8, and I want to take some questions. So Amy, I think I will stop screen sharing. And can I just take questions or? Yeah, okay. John, I see your hand up.
Yeah, hi, Bob. Linda says hello, John Wynn. And the question I have is about right now, it doesn't cost us for Alaskans or Juneau residents for the testing. I'm assuming that's being paid by the federal COVID dollars. Once those end, how is that going to be charged?
Yeah, John, thanks so much for that question. That's a fantastic question. So you are correct. All of the COVID testing costs right now are being paid for by the federal CARES allocation, either directly through the city, or actually most of that is being paid by the state's CARES allocation right now. The best case scenario is that there will be another CARES bill coming out of the federal government to pay for COVID testing related costs. If that doesn't happen, then we're going to be reliant on FEMA, the Federal Emergency Management Authority reimbursement options, which is challenging and not really a process that we want to go through, but we will. And then the alternative to that is state funding, local general fund funding, and private insurance and self-pay. So they're not great alternatives, and COVID testing is not cheap. What other questions are out there? Amy.
Well, hello. I'm thinking ahead to possible travel in the springtime. And it's great that we're going to have this testing facility machine here in Juneau. And to go to Hawaii, I've noticed that you need to have a certain type of test and need to have a certain test from a certain lab. Could you explain whether that's been thought of at all at this point?
Yeah, so the Hawaii travel, I've gotten that question a couple of times. We love to go to Hawaii. And the state of Hawaii has a great website where they list out all of the different types of tests that they are accepting right now. Unfortunately, the only type of test that they would accept right now that you can acquire here locally is one of the tests by mail. And I'm blanking on the specific vendor name. I bet Dave knows the answer to that, but there's a specific vendor, and I will find it, and I can send it to you, Amy, and you could send it out to the group if you want. But you have to purchase it and have it shipped to you, and then you collect the specimen yourself and ship it back. And it generally costs in the vicinity of $150. So they're not yet accepting any of the molecular tests that we do here locally.
Seems like it'd be hard to get the result in 72 hours if you're sending it from here, and but I'm sure things will evolve in the next few months as well. Yeah, they
absolutely will. Yeah, Rosemary.
Oh, can I, actually just, Robert, you said you could stay after and answer a few questions. It's pushing up to 8. So I'm going to end the official meeting. And if you can stay on and answer questions from other people, that would be fantastic.
Sure.
Okay, thank you. So I'm going to remind everyone to sign up for the auction if you have not already done that, and invite your friends. I think Colleen is going to send out an email that we can forward to our friends and family to join us for the meeting. Don't forget to send the Glory Hall information. If you have some things to donate to that, send that to Candy. And otherwise, we will see you all on Tuesday at the auction. And thank you for staying on, Robert. More questions, go ahead.
Rosemary, you're muted.
Yeah, I just want to thank you, Robert, for your leadership on this whole process. It's been immense. It's been sort of tedious and super involved, and it's been kind of a long haul. And I'm very pleased that we are finally getting our PCR machine here. But I just want to point out that That PCR machine will help us to welcome the legislature to town. It also will help with getting kids back into school. And hopefully by spring and summer, it will help us to get back our cruise ship industry, at least to begin to get it back. So, you know, all of these tiny steps come together to make a big happy ending, hopefully. So thank you very much.
Robert, John, again.
Sure, John, go ahead.
Hey, Robert,
the
this is
potential.
John Pugh.
Both
What,
Johns.
that, given that what Rosemary said about the travel industry, what are going to be the requirements? Do you know that yet in terms of
No.
their testing? Have we gotten any information yet from on that?
You know, Rosemary's answer is the correct one from a succinct point of view. No, the latest that I've heard from the travel industry is that they, it appears that the CDC will be requiring each cruise ship company to make individual plans with every port of call. But what those plans, there's some guidelines around what those plans should look like, but they're not particularly specific at this point. My expectation is that we'll use the plans that were developed for cruising in the Caribbean and the Mediterranean as a starting point, but don't really have many details yet. Rosemary's answer is the right one.
Thank you.
Yeah.
Other John Wynn.
The other the vaccines that are coming out. What are the plans and who are their priority people who are going to get those vaccines?
Yeah, good question. So the Division of Public Health is going to be leading our sort of vaccine coordination efforts here locally, you know, what I've heard from being on the statewide vaccine calls is that the prioritization work is still really a work in process. But we're going to be, I'm sure, talking about healthcare workers and first responders for probably head of the line, and then likely shortly thereafter those with you know, underlying health conditions that would make them more susceptible to serious COVID impacts. One of the interesting things to know about vaccines is I say all, I may be safer in saying most because I'm not certain that all is the correct word here, but at least I'm only aware of clinical trials that are studying vaccine efficacy in adults, 18 and up. I'm not aware right now of any vaccine trials that are studying vaccine efficacy in children, which means that it's going to be a while until children are being vaccinated for COVID.
So how will people be notified that they're eligible for the vaccine? Who's going to contact them? Their physician?
That's a good question that we don't have a good answer to yet. Likely, well, not likely, certainly all private medical providers will be involved in vaccine distribution. And there will definitely be a lot of public communication going out through both state and local channels. What other questions are out there? I see Amy's hand.
Well, I heard on a call the other day that legislators were going to be asked to stay in Juneau for the duration of the session. And those sessions can be pretty long these days. Or I don't know if that would be a requirement or a request on them, or what kind of protocols are you folks envisioning for them to be tested and just quarantine here in Juneau?
So we've been working with Legislative Affairs and Legislative Council on developing a mitigation plan for the Capitol that is tied both to our risk levels and to a sort of risk mitigation strategy that the legislature themselves are creating. So our intent is to, should we need to be able to be in a good position to provide testing for their staff and to coordinate with them on what the appropriate mitigation strategies for the Capitol are in relation to the state of COVID, the current situation in Juneau, and as it evolves. So things like, you know, strategies around distancing and masking, those ones that we've been dealing with throughout this whole time, but also levels of access for the public to the Capitol, levels of access for the media to the Capitol, and those sorts of things. Insofar as quarantining requirements go, you're more up to speed on than I am on that one. I haven't had a chance to talk with them about that. I don't think there's likely to be much in the way of requirements for quarantining for legislators. I think it's going to be more of a recommendation and voluntary compliance sort of strategy. I do think they are likely, well, I don't know. I was going to say I do think they're probably likely to be on board with the masking and testing issues, but that might be more voluntary compliance too. I'm not sure at this point. John.
Another question. Can we quarantine the legislators in the Capitol building until we resolve the budget issue?
No comment.
There are other questions? You can speak up. If you're still on and you have a question.
Robert.
Thanks, Robert. That was great.
Well, thank you, John.
Yeah, thank you very much, Robert.
Robert, Mitch, have a question?
Yeah, just a question. I mean, it's going to take you several months to get all the testing equipment in place, and what's the tail end of this thing look like? I mean, are we looking at something that goes away, or are we gonna spend $1 million up front and have it obsolete by summer?
Yeah, that's a good question. Part of the answer to that question is I really wish I had a crystal ball and could make a prediction that was accurate. One of the things that I'll say is that the piece of equipment that we're buying is not only used for testing COVID. It can be used for other types of diagnostic tests in the long run once COVID is beyond us. It's a very multifaceted piece of equipment. Now, it is fair to say though that Bartlett, given its size and given just the size of our community, would generally not choose to purchase a piece of a system of this caliber if COVID were not present. So there's a little bit of give and take there. Insofar as the long tail, sort of where this is going, my best guess is that we will be dealing with COVID all through 2021, and hopefully to a much lesser extent and lesser degree than we're dealing with it right now. Certainly the vaccine news that we're hearing right now sounds relatively promising, and as this vaccine becomes available, that should decrease our need for community mitigation strategies, for mass testing efforts. But no vaccine is perfect. Even the best vaccines are generally in the low 90s percentage from a percentage efficacy point of view. So COVID's probably not going away, and there will be plenty of people who opt not to get a vaccine. So there's that too. So yeah, I think we're going to be happy that we have this system in place, and that we will likely be using it for at least a good year. Kim. Oh, Kim, it's good to see you.
Nice to see you. Thank you for a great presentation. The machine that Bartlett's getting, can it be backup for Anchorage or Fairbanks? If something happens with their machine, can our machine kick in and help statewide?
Kim, that's a great point. Yes, the system that we're using is very similar. It's identical. So one of the differences, the Fairbanks lab in particular, also the Anchorage lab, have multiple systems from multiple vendors. And this is one of them, one of the vendors that they use. Well, should be careful in saying that. I believe this is one of the vendors that the Fairbanks lab uses. But in any case, yes, the manner in which the specimens are collected are the same across all of the types of complex laboratory PCR-based testing that we do. So yes.
Great, thank you. And thanks again.
Yeah.
Amy again.
Amy.
It sounds like supplies are still short for the Abbott type tests. And you mentioned that this machine has been ordered for a while now. So obviously they're not something you can get instantly. What other supply issues are still existing in this whole COVID world that could be?
Yeah, so that's a good question. Supply issues are still a real concern. So all of these machines that run in complex laboratories require reagents, and they require plastic material supplies in order to operate them. And so those are kind of the two broad categories. And you know, the vendor that we're operating with, their name is Roche, R-O-C-H-E. They've been able to give us as much confidence as really any vendor that they're going to be able to supply the reagents and plastics for the machines that they deliver. I would actually say they've given us a higher level of confidence than the other vendors that I've been working with. That said, you know, it really just depends on the state of COVID worldwide. So they're a worldwide company. Most of, probably all, but certainly most of the vendors that operate in this space are, and they allocate their commodities for their systems based on need. And it just depends on what we see. Now there is going to be a floor, and that floor of supply is going to be far higher than our ability to run tests on the Abbotts and the Cepheids, on the rapid tests that we have right now. So it's an improvement any way you look at it. It's just a sort of a moving target as to what our long-term supply is going to look like. John.
Robert, I saw on TV one of the Alaska Native Medical Centers up north, I'm not sure where it was, has 2 machines to do a huge amount of tests now. Are you aware of that? And is that a possibility for testing up there?
So are you referring to ANMC in Anchorage or
I don't
further?
think it's ANMC. I think it's, I'm not sure which one it is, but they had something on TV the other day about, and they have 2 machines now. They can do a huge amount of tests up there.
Yeah, I mean, I know ANMC has multiple machines, and I know that the Fairbanks lab has multiple machines, as does the Anchorage lab. I'm not aware of any other laboratory environment in Alaska in the public sector that has multiple machines. There is a commercial lab that is starting up in Anchorage that will be able to process thousands of tests per day. I couldn't tell you how many thousands though. And there is also a commercial lab that is trying to start up here locally. So we may have some commercial opportunity as well. I had my first conversation with them early this week. So there's some opportunity there as well.
Well, all right, well, thank you for being here, Robert. I don't think there's any more questions.
Yeah.
Really appreciate you being here. That was really interesting. We're looking forward to getting that machine here in Juneau.
Thank you all. It's really good to talk the details sometimes. I don't get the opportunity very often. So.
It's great to see what you can do with the library degree. You can pass it on to Linda as well, John.
Yeah.
All right, well, have a great day, everyone, and we'll see you on